everyone, I'm Fiona Clarke from Hello Menopause and the Menopause Research and Education Fund, and I'm co-hosting today the Skin Diary podcast on ageing skin, and we are talking about acne. Joining me, of course, is our lovely co-host, Clare Kiely, who is a co-founder of the Skin Diary. She is also a consultant dermatologist with a special interest in skin cancer and photo-damaged skin, has a master's degree in skin ageing and aesthetic medicine, and is an executive board member of the British Cosmetic Dermatology Group and an honorary lecturer at the University of Manchester. We're also joined by consultant dermatologist Anjali Mahto, who is not only a great consultant dermatologist, but also has a diploma in nutritional science. She is the author of The Skin Bible, which is an amazing book which has now been translated into 11 different languages. She's worked in some of London's most prestigious skin clinics, but has now set up her own, the Self Clinic on Harley Street. It takes a very holistic approach to acne and medical and cosmetic skincare issues, and if you understand Anjali's journey through with her own skin, you'll understand why, which she will explain in a little moment, because it is a very interesting story, but she's also an icon in the industry, isn't she?
She is definitely an icon. Thanks for being here today, Anjali. In the dermatology world, Anjali is inspirational, I think, to a lot of us female dermatologists, because she's one of the only female dermatologists to set up and run her own medical clinic and business very, very successfully. And unfortunately, in medicine, you don't see that many clinics that are run and owned by female medics, Anjali. So well done and congratulations for making a huge success of that. The other thing I think Anjali is really inspirational for is she's taken something that some people might think of as a flaw, you know, having active, stubborn acne into adulthood isn't great. But Anjali has turned that into her superpower, and she's really trying to do something, and she's out there trying to better the lives of other people with acne and being very honest and open about it. So it's an absolute pleasure to have you with us today.
Thank you. That's such a generous introduction as well, both. I really appreciate that.
But it is your personal story that makes it so different, really. When you look at the website for your new clinic, you can really see that coming through. So just give people a bit of a reminder of what it is that you went through and why it is so important for you.
Yes, so I am now in my mid-40s, so I'm nearly 45, and I developed acne for the first time at the age of about 11 or 12. And as many of us know, I mean, being a teenager is hard enough. Life then was pretty difficult for me as well, to be totally honest. My father had just died, and the acne came on within a few months of that. And we're not talking the odd couple of spots. We're talking really deep, cystic, painful spots. I was going through a bereavement. I was quite young and moved countries, moved schools, all within the space of about 2 weeks.
That's a lot, yeah.
So it's really weird. But for me, acne was one of those things that I put all my I always felt like if my skin could be better as a teenager, my life would be better. It was such a thing for me. And I think growing up all that time, went to an all-girls school, people were super judgy about what you looked like. Mm-hmm. And I just remember thinking, you know, if this is my lot in life as a teenager and this is going to be the best it's ever going to get, you learn very quickly that your self-esteem does not come from what you look like. Mm-hmm. And there's got to be something else about you that you're able to do. I mean, my acne persisted. My mum was not keen on me taking isotretinoin, which is a very good treatment for acne in the right patient. And eventually, I think I got to A-levels and was like, I'm not going to university continuing to look like this. I had scarring by then as well. So I had my first round of isotretinoin just before going to university. And quite honestly, it was life-changing. But the acne came back, and the long and short of it is it's always come and gone over the past 30 years now, coming up to. So I've just had to come to terms with a lot of people that suffer with a chronic illness that it's never going to go away. I just have to learn how to manage it and not expect a cure from it. Mm.
It's interesting because you mentioned chronic illness there, because a lot of people don't actually really think about acne in that way. There are a lot of myths and things that come with it that, you know, that it's, you haven't looked after yourself, you haven't eaten well, your hygiene isn't good. Where do they come from, and how do you then explain to people that, no, actually, this is actually a condition of your skin?
I think it's very difficult, isn't it? I think all of us will probably agree that social media and the way that it is at the moment, there's almost a moral judgment associated with skin disease, be that acne, eczema, psoriasis. It's almost like, well, you know, what you're putting into your body is a reflection of what's on the outside. You mustn't be eating properly. You mustn't be looking after your lifestyle. Have you tried to cut out dairy? Have you tried to cut out sugar? You know, all of the classic things that I think people with skin disease have suffered with, I've heard at some point. And it is difficult. And I think that's why podcasts like this that you're doing and raising education and awareness and it coming from an expert space is so important.
I want to come back to the dietary things in a minute, but I guess you mentioned you started in puberty, but then when you get to your 40s or so, when you sort of hit perimenopause, which could be earlier, it could be much later, and just when you think that it's all sort of gone away, it comes back again. So is it the hormones? What's going on?
I mean, female adult acne is very, very common. So if we just kind of look at 20s, 30s, then getting into perimenopause, early 40s, what you will find is there's a group of women that had acne as a teenager and then it just grumbles on. They never really grow out of it. So I'm in that category. But then you have a group of women who had great teenage skin but develop problems around the age of about 21, 22. And it's completely new to them and they don't know how to manage it. But then as you get a little bit older, so you get to your late 30s, your early 40s, we do know that we start to see hormonal shifts that can drive acne. So the main hormone that drives acne are a group of hormones known as androgens. So these are male hormones like testosterone and dihydrotestosterone, but even women have these. And what happens as we start to creep into menopause is our female hormones start to drop a little bit. So you start getting drops in hormones like estrogen. But your male hormones remain relatively constant. So your androgen hormones remain about the same. So the ratio that you've got between those male hormones and those female hormones that are dropping starts to change. And that can trigger acne for the first time in people in their 40s.
Mm-hmm. It's also a real problem with facial hair developing. People get really upset because they're developing, chin hair and a mustache. And then by doing all of the things that you might do to get rid of the hair, like laser hair removal or epilatory creams or any of those things, sometimes that, triggers a folliculitis, which can look like acne or can kind of trigger an acne form eruption. So all of these hormonal shifts can have multiple sequelae.
You just can't win, really, can you?
No.
It's tough being a woman, isn't it?
It is. It absolutely is. Do you treat it the same way, though, as a teenage acne? How do you approach it?
I'd say as a general rule, yes. I mean, acne is multifactorial. We're just blaming the hormones, but it's not just the hormones. It's the hormones. It's the way the oil glands are fairly big, plump and juicy. It's about the fact that the skin cells, they don't shed the way they're supposed to and they become sticky and they become clumpy, so your pores can get blocked. But then there's also the issue of the skin microbiome. Our skin's got bugs on it, just like our gut does. And people who are acne prone do have certain strains of skin bacteria that can cause acne itself. So it is multifactorial between the hormones and the oil glands, and then the sticky cells, and then the bugs that you've got living on the surface of the skin. So as a general rule, I think probably, Claire, I'm sure you'll agree with this as well, but the approach that we tend to take is you look at the type of acne that you've got. Is it comedonal? Is it little blocked pores underneath the skin? Is it a little bit more inflammatory? Have you got pustules, whiteheads, or are you getting the deep cystic spots that are creating scars, the indents or the raised things that you can see in the skin? Mm-hmm. And depending on what you can see, that will guide your treatment pathway. But the ultimate treatments are still probably the same.
I think it can be very, very tricky for people themselves looking at their own skin to decide what type of acne they have, if they have acne, if they have rosacea maybe, if they have folliculitis, or even this other condition called perifollicular dermatitis, which we see a lot of with overuse of products. But people often come in when they're really at the end of their tether and they're very, very confused and they've used lots of products. And for us, the differences can be quite subtle, but you do need a trained dermatologist's eye often, unfortunately, to just set you on the right path sometimes. People can kind of go down these rabbit holes of really trying to do lots of research themselves. And as you said, social media, and they've spent nearly a year on all sorts of different products and gotten advice from all the wrong people, and then they eventually arrive at your door. And I think sometimes people worry a little bit about coming to a dermatologist because we realise, it can be expensive and, not everybody has access to that. But oftentimes it just takes one visit to be set on the right path. And often what I do is I will give people a treatment plan with, over-the-counter treatments, topicals, and possibly orals, and maybe lights and lasers. But oftentimes it's just topicals. And then you say to them, this is your plan A, this is plan B. one of these is going to work, and then your GP can just re-prescribe this for you. Just even coming and getting that once over once to be told, this is what you're doing wrong, this is what you need to do, this is the condition that you have, whether it's acne or rosacea or perifollicular dermatitis, can often just change the course of how their skin goes completely.
I agree. And then you've got the ones that have got the slight overlap with acne and rosacea. We assume that everyone with acne has got super oily skin, but we know that's not the case. We know that we've got people that have got sensitive skin. They are rosacea prone, but they're still suffering with acne as well. And their skincare will be completely different to the oily acne prones.
Yeah, because sometimes with rosacea, especially in women who have kind of sensitive skin, say in their 40s and 50s, they might have that type of rosacea where they're getting pimples, but they also have patches of sensitive skin. And if they're using the very kind of drying products that with salicylic acid and benzoyl peroxide that you might use for a very oily teenager, then their skin is just really going to hurt, because it's going to dry out quite quickly. Because as you get older, your skin barrier isn't as good, especially postmenopausally. If your ceramide levels are lower, your hyaluronic acid levels have dropped, things like your sebum production aren't as high postmenopausally. Those kind of quite harsh products that can be quite stripping if you're using them all the time can just really cause a lot of sensitivities in older skin types.
True. With that, because with the skin barrier, also with acne, I think there's quite, not just rosacea acne, but with acne itself, there's emerging evidence that it can be a compromised skin barrier, and that those things that are quite good for the sensitive rosacea type skins, the niacinamide and the ceramides, could be quite good for them as well, because we often think if you've got acne that, it's oily and you don't have to moisturise your skin. But I think they're finding now that more and more that you do actually need to moisturise it to get that skin barrier back into a healthy state. Is that correct, and do people understand it?
No, that's absolutely correct, because there is a difference between sebum or oil levels in the skin or water and hydration in the skin. So you can still have oily acne-prone skin that still may be dehydrated and lacking in hydration. So that moisturiser is really important. And actually that sunscreen is really important as well. And that's because you want to reduce the marks that the acne itself will leave behind. So you want to reduce the risk of pigmentation or post-inflammatory erythema or the redness that spots might leave behind.
Yeah, absolutely.
Niacinamide's one of those kind of all-rounders that's pretty much good for everybody. It's very, very rare for people to have a reaction to niacinamide unless it's formulated at too high a concentration. One of the things I'd like to hear your view on is double cleansing, Anjali, because a lot of people do that. I think a lot of people don't even realise that they're doing it. They might use a micellar water and then use a foaming wash, and you'll ask, are you double cleansing? And they'll say, no, I'm not, but I use my micellar water and then I use my wash, and I'm thinking, well, that is double cleansing. What's your view on that?
So not everyone needs to be doing it. Now, for me, I am super oily and I wear makeup and I wear sunscreen. So at night time, I do need to double cleanse to make sure that all of that comes off at the end of the day. First thing in the morning, I went to bed with a clean face. I don't need to double cleanse in the morning. So if we extrapolate that to, generally speaking, if you are somebody who is not a heavy makeup wearer, you're not somebody that's putting loads and loads of mascara on, and you've got a decent cleanser, you can get away with cleansing once. And by double cleansing, if you are sensitive or you are dry, you might end up stripping the skin and impairing that barrier function. So this goes back to that it's not a one size fits all. And different skin types need different things.
I think sometimes people with acne prone or oily skin want to feel that nearly kind of squeaky cleanness, which you get from soap, which we really don't like, because it means that you've probably overdone it. The micelles and the micellar water kind of are surfactants that suck up all the oil and dirt, and they do that very well, and they're very, very good for eye makeup. Actually, people don't realise that micellar water is actually great at taking off makeup. But yes, I agree, it depends. If you are a person who wears very heavy makeup and you need to double cleanse, do that. If it's just that you have gotten up in the morning, then you probably don't need to double cleanse.
What about scrubs? We know that even in perimenopause, people will reach back when they see those pimples coming up for the scrub to take all of those things off. Friend or foe?
Again, I think it depends on the skin type. I mean, essentially all you're doing with a scrub is you're exfoliating. You're removing that upper layer of dead skin cells. So you can either chemically exfoliate or physically exfoliate. So either use your AHAs or your BHAs, or you use something that's got granules or bits in it, or you use a flannel, or you use a cleansing device. So there's all sorts of ways you can do it. And here, again, I think it depends on really what your skin barrier is like. So I would recommend I am oily and I'm acneic. I can do anything to my skin. I could scrub it. I could use chemical exfoliators at the same time. I would have no problems.
Whereas I'd be red for 9 months.
Yeah, exactly. But if you've got dry skin, your skin is dehydrated, you are noticing your skin is becoming more dry as you are getting older, I'd probably say you want to put the physical exfoliators down.
Yeah. Yeah, I think actually I can see it with the difference between the atrophic photoaging skin types and the hypertrophic photoaging skin types. So people who tend to have rosacea, thinner skin, that kind of atrophic, very sensitive skin type, you just have to be very, very careful with those. I mean, I think with things like Anjali was saying, armamentarium is kind of made up of a couple of treatments, but we use them in very different ways. So things like the vitamin A's and the retinoids, you can still use them in people with very, very sensitive skin, but you just use them at much lower levels and you introduce them slowly and gradually. But, again, in people with very, very oily or thicker, kind of the more hypertrophic photoage skin types, you can use, very, very high concentrations of retinoids quite quickly. Yeah. And as you said, all of the acids and things, and their skin is absolutely fine.
People are often quite scared of prescription level tretinoin and vitamin A's. Should they be? Are there good ways of managing the dryness and the irritation that comes with them?
I think there absolutely are, actually. And I think here, again, it's the education part of it. And as Clare said, you build up slowly. You don't have to start everybody using a product every night. I mean, in clinic, if I was going to start somebody on tretinoin, for example, my advice would be small, pea-sized amount, after cleansing, thin layer, full face, avoid your eye area, only use it once or twice a week, do not use it on consecutive nights, and then put your moisturiser on immediately afterwards. And you want to make sure you get no redness, no peeling, no flaking, no soreness. And if you are okay with that, then maybe try 3 times a week or 4 times a week and so on and so forth. And then plan B is if that doesn't work, they moisturise first, then they put their vitamin A on.
Yeah.
And then if that doesn't work, they moisturise vitamin A and then moisturise again.
Yeah, you can sandwich your tretinoin between your moisturiser. I mean, with all of those, that's rules to live by. I mean, Anjali is basically that is the tretinoin or retinoid rules to live by. I mean, you just introduce it slowly and work your way up and then moisturise. It's such an effective treatment that you don't want people using it too much and then thinking they're having a reaction to it and then saying, I'm never going to use that again. So, we try and lead people into it and warn them, look, if you're having a reaction, it's just that you've overdone it, just pull back. But generally we can get most people on it, just people need hand-holding and guidance.
Yeah, absolutely. Yeah. Once they've got a sort of handle on it and we're in that sort of maintenance phase, because as you said, this is a lifelong chronic battle, what would you want them to be using at home? If they're going into a shop and they're thinking, here's this whole great, especially these days, the menopause acne ranges that they'd see on a shop shelf, what should they actually be looking for?
So are we assuming acne-prone skin in menopause, or are we talking about kind of aging skin and menopause in terms of an ideal routine?
One or the other. Both, actually, yeah. So give me the acne-prone one first and then the sort of rosacea acne-prone person.
So I always feel that the basics or backbone of a skincare routine is pretty much the same. It just might be concentrations are different, and then it might be a few additional things that you do. So as far as I'm concerned, the basics of a good routine are you should have vitamin C in the morning, vitamin A at night. Make sure you've got your sunscreen, factor 30 to 50, depending on your skin type, on a daily basis. Now, let's assume everyone is doing that, and they've got a Vit C and a Vit A that is an appropriate concentration or formulation that agrees with their skin. If you're acne prone on top of that, you may want to add in a few other products here and there. So if you're oily acne prone, you may want to add in something like a beta hydroxy acid or your salicylic acids. If you are not particularly oily, but you are prone to kind of combination skin, I might switch to something like a mandelic or a lactic instead. So you're using an alpha hydroxy acid instead. If you are getting the odd spot or the odd breakout, I might say use a little bit of targeted benzoyl peroxide as you might need it. But I think the basic routine for everyone, be that acne, be that aging, be that rosacea, you should still have your Vit C, your SPF, AM, and then your vitamin A, PM.
Okay, this is interesting because you mentioned vitamin C there, and a lot of people will say acne-prone skin, no vitamin C, irritating, going to make it worse. But that's not the case?
Yeah, and again, I think here it's about formulation And it's also potentially about concentration as well.
I find that with my patients that if they are having problems with vitamin C, I think it's often because the formulation it has to be formulated at a low pH. So I actually get them to put it on different days, because a lot of the early studies done by Sheldon Pennell, who did a lot of the vitamin C studies, showed that it actually has a half-life in the skin. So even after 4 days post-application, it was still there. So I think maybe that, we are altering the microbiome a bit by putting on all these products. So, and vitamin C, because it's a much lower pH than your skin is an acid mantle anyway, so it is a bit acidic, but just not at that low pH that vitamin C has to be. So oftentimes if they just alternate it or just put it on even twice a week or 3 times a week, you can still get the benefits from vitamin C and not so much the reactions. But yes, we do sometimes see people who just say they can't tolerate it, but either I will tell them just change brands, because it could just be the formulation, or alternate it.
Yeah, and then you could use azelaic acid in the in-between days, which is, again, it's an anti-inflammatory, it's anti-redness, it's got some anti-acne activity as well, in those 3 or 4 days a week that you might not be using it.
Yeah, we love azelaic acid.
Yeah.
I think it's actually most people who come in with, whether it's acne or pigmentation or rosacea or even just aging, probably putting azelaic acid somewhere in their skincare routine. It's just such a safe, great skincare ingredient.
And well tolerated. That's the key thing about it as well.
Yeah.
Yeah, absolutely. You mentioned earlier stress, and this is an important one because obviously as well, when we get to perimenopause, it's not just hormones that are going haywire. Most of us will have teenage children, ageing parents, jobs. But, our life, we really are that sandwich generation where life is throwing everything at us. How much of a role does stress really play in acne?
I think dermatologists, even when we were training, we recognise that there's absolutely no doubt that stress can aggravate chronic inflammatory skin conditions. So I'm sure we're both in the habit probably of asking patients when they come in with a flare-up of their skin condition, you do say, well, has anything been going on over the last 12 months? Is there anything major going on in life? It's important to know these things. The problem is, how does one remove stress from modern day life? It's impossible to do so. We don't live in a perfect world. So the next best thing is actually recognising and acknowledging that that can be a trigger. It won't be the cause. You've probably got to have the underlying tendency to that condition in the first place, but it certainly can make things worse. So how do you find methods of managing that stress? And I think that's where we all have to take a little bit of personal accountability of getting our work-life balance right, finding a way to be able to unwind, getting off social media, whatever it might be that works for the individual.
Yeah.
That's why your clinic is taking this kind of very holistic approach. Do you have a psychologist in there?
We do.
Yeah.
We've got a psychologist and we've got a dietitian.
Yeah, amazing.
It is.
It is one of the questions we often ask people, and they will often, when you say to people, has there been any stress in your life? Was it around this all flared? People will sit back and say, yes, my relationship broke down. I started a new job. There's often something. Yeah. But again, how can you manage that? But we often tell people, it's multifactorial, so it's not just the stress. Obviously, if you can reduce that and manage that, but things like diet and lifestyle and hormonal fluctuations and all these other things, and we can only manage what we can manage, but giving people advice around reducing stress is good for their general health and well-being and well-aging anyway, so we do try to do that. Oftentimes I would say, look, I would love to just prescribe you a stress-free life or, a 2-week holiday, but unfortunately we can't do that.
No, it would be nice though, wouldn't it? You mentioned diet there. Now there's almost an industry in acne diets. How much do we know about what elements of the diet, if any of them, do make any difference to acne, especially, say, things like dairy or sugar?
My top line advice on this always tends to be a diet that is good for your skin is a diet that is good for your general health. So it's good for your gut and it's good for your eyes and it's good for your heart. There is no special skin diet per se. If you actually look at the evidence of diet and acne itself, I mean, this is a long-standing saga in dermatology textbooks where we've gone one way, then the other way, and then back again. And most of the studies and most of the data do show that for the majority of people, dairy probably itself as a food group, and it's a massive food group. It's not just milk. It is still cheese, which can be fermented. It still is yogurt. So there are things that we have to think about there, is that for the majority, it probably doesn't make a difference. Now, that doesn't mean that there isn't a small select group of people that find that when they have dairy products, their skin flares up. And I think those people generally know that. They know that every time they consume those types of foods, they will get an acne breakout. Again, if you break down the data that we've got even further, there seems to be a difference between whole milk and skimmed milk. And it seems to be that whole milk seems to be better for your skin than skim milk. But then the question is that because you essentially removed the fat from the skim milk? And then is it the carbohydrates that are left behind that are causing the problem, not the dairy itself? So I think it's very, very difficult to conduct controlled studies on nutritional sort of data because there's no clear cause or effect. So that's one thing. The second thing is sugar that comes up a lot. And there is emerging evidence that foods that have got a high glycemic index, so foods that spike your sugar levels very, very quickly, may have a role to play in female adult acne. Now, again, I don't think the answer here is we cut out sugar altogether. I think it's just about mindful choices. You can still have that glass of wine or that cookie or that cupcake, provided that's not what you're doing every day, and that you're still getting healthy grains and healthy fats like your omega-3, that your diet is comprehensive enough that you've got your iron, your vitamin C, your selenium, your zinc. I think the bigger problem that I see in clinic is people cutting so much out of their diet because they're so worried about their skin. I mean, the internet will have you believe that if you cut out sugar, you cut out gluten, you cut out dairy, you can cure every skin disease. And
you've got nothing left to eat.
Well, you've got nothing left to eat, but it's a very simplistic approach to what is often multifactorial. And then those people often usually are the ones that are actually then deplete in nutrients and probably having further issues around not just skin, but general health, hair shedding, but also mental health issues that may go with that from becoming really paranoid about what you can and can't eat. So,
because it goes back to that judgmental approach that you said in the beginning. It's a very external judgmental thing. Well, it's all your fault because you're eating the wrong thing.
Do you know, about 5-6 years ago, I posted a picture of me having an ice cream on a sunny day on my Instagram. And you know the amount of comments I got that said, well, no wonder you're spotty because, you eat ice cream on a sunny day. But this is the thing. I've firsthand seen it as well. So absolutely, there is a judgment that goes with that. And you can see that if you are vulnerable, you are a little bit younger, and someone's saying that to you, you almost don't want to be that person who's got a face full of spots eating certain foods in front of somebody else because they might shame you for it.
The stigma that's involved in that is just, that's really, really upsetting because if that's being said on social media, then that's probably pervasive.
100%.
And that's what young people are hearing from each other. But yes, we are here to tell you that it is not down to what you are eating. A healthy diet is just a healthy diet, and it's always been the same. Eat your fruit, your vegetables, your grains, and then minimise the amount of sugars and alcohol and all the bad things. I mean,
fat,
it's very. People love asking us this question, but you kind of knowingly look at them and go, "You really know the answer to this." Everyone knows. It's just tricky, but it's a struggle for all of us trying to keep our diets very healthy.
Oh, absolutely. I think disordered eating now in perimenopausal and menopausal women is skyrocketing because not just because of skin and those, but also because we get fatter and we're feeling shamed on every front really, which is so kind of like the last thing that you really need to deal with, frankly. In all honesty,
I think it's getting worse as well. I think with the fact that we do have social media the way that it is, it's hard on young people coming through because they've grown up with it. But I think it's even harder. As adults, we recognise it's not real life and people are presenting their best version of themselves. But if you wake up one morning and you're having a bad day and you look at it, it's very easy to get sucked into it.
Yeah. The level of perfection that's expected is really extreme now. I mean, I'm seeing a lot of patients coming in with acne scarring and really expecting that their acne scarring will disappear after treatments, and it's really impossible to do that. And it's really, really tricky because people can spend their lives searching for an answer. And I've had a lot of patients who've come in and gone to multiple different doctors and multiple different dermatologists, and they will say, oh, you're the one, you're going to fix this. And you really have to lower people's expectations. But I think a lot of that is driven by social media and this expectation of perfection. And a lot of the consultations that we have with patients now are about acceptance. And I think that sometimes just coming to us and having that talk and explaining that this is completely normal and a lot of people's skin looks like this and, that they're not doing anything wrong. And, getting people to accept themselves is very, very important.
That's a hard, difficult conversation. We'll come back to the scarring in a minute. But before we get there, you also mentioned probiotics and the microbiome on the skin. We see an awful, in social media, you've got to love it, we see an awful lot of things that are thrown up there, you know, shoving yogurt on your face, you know, supplements for with God only knows how many, 20 billion lactobacilli or whatever it is in a tablet that are going to make, if you eat this, you take this, or you put it on your face, it's going to make it better. Is there any evidence that any of those actually make any difference to acne-prone skin?
No, I think,
or rosacea-prone?
I think this is all still really, really super new data. You know, we still don't know. I mean, first of all, your gut microbiome is completely different to your skin microbiome. Secondly, your skin microbiome isn't the same in every part of your body. It is different in oily areas of your body than in areas where your skin folds meet, like your armpits, for example. So the first thing is, it's, again, too simplistic to say that the stuff in your gut, which, by the way, is a drop in the ocean, because your gut microbiome is still made of, like, yeast and fungus and viruses and mold and bacteria, not just the 5 strains that you happen to get in a little shot, for example. So that's why I still always think it's better from your diet than from a supplement where you can. But then what we don't know is, how does the gut microbiome speak to the skin microbiome? Does the skin microbiome speak back to the gut? Do we know, or do we not know, whether you take stuff that's made for the gut and shove it on the skin and suddenly your skin bacteria are going to be very happy with that? So I think this is a watch this space. I think that there will be new data that will come out, and there will no doubt be patterns of microbiomes that we will see, and different people will need different things on their skin. So there will come a point, I think, where there will be personalised topical skincare that will actually probably help the individual that's got acne versus rosacea versus psoriasis versus eczema. Do I think we are anywhere near that at the moment? Absolutely not.
Yeah, that'd be a really interesting phase, actually. I love that idea. It's a really good idea. Speaking of disgusting things, though, that people put on their face, have you seen the latest TikTok trend?
I don't know.
Yes, you should look afraid. Excrement, human excrement on your face.
I mean, why would you do that?
Let's not even go there.
Why would you do that?
I don't know. That's what I thought. Why would you do that?
Oh, goodness.
Apparently it's a thing.
This is why I don't have the TikTok app on my phone or an account.
Yeah.
No, I don't look at it either.
I'm going to have an influx of people.
I played with it a couple of times and I thought, no, really, this is a space I'm really just don't particularly want to be in. You mentioned sunscreens earlier as well. Now, there are a lot of people who with acne will probably go, oh, I can't use these because they're so thick, they're so gluey, they just make my skin worse. What should they be looking for in a sunscreen?
I mean, I've got to say, I sympathise with this. I still, despite being a dermatologist, detest wearing sunscreen because I hate the way that it feels on my skin. But I think as a general rule, look for textures. So go for something that's light and gel-like rather than a thick, greasy cream on your skin. Second thing I would say is not everybody needs to layer a serum and a moisturiser and a sunscreen. For some people, you know, that sunscreen still comes in a moisturising base. So for them, maybe they just need their serum and then a sunscreen on top. So for me, if I wear sunscreen, I'll use a vitamin C, then I'll put the sunscreen on immediately, but I will skip the in-between step of the moisturiser. So those are two things I would say. So oil-free preparations which do label themselves as non-comedogenic. I mean, that in itself is a separate conversation about whether or not it genuinely is that or not, but it's probably better than something that doesn't have that title on it.
It's interesting. I had a conversation with a cosmetic formulator about this recently, and the reason why they've been very greasy for years is to do with the filters and to do with them being photostable. But we have much better filters now, so the sunscreen formulations are much more elegant. And I think the key is in what Anjali said, that it's very, very different depending on your skin type. Yeah. As Anjali said, she likes the more kind of mattifying, non-oily sunscreens. Yeah. However, I am a person who likes the kind of creamier ones because exactly like that, because my skin's a bit drier, I just put my serum on and I want my sunscreen to be my moisturiser. I don't want to have to do that extra layer because who has time in the mornings? So, you know, not oily but creamy. And I think that that's something that the formulators have actually only been able to do in the last 2 or 3 years because we have great filters now. But it's picking something that you like and that you will actually use every day. And I think nowadays there's definitely something for all different skin types. Some people react to some of the newer filters, some of the chemical filters. And for those patients, we would say, try a mineral sunscreen, so zinc oxide or titanium dioxide.
Now, you mentioned, again, which we need to come back to, the things that are often mistaken for acne that aren't acne and products that people are putting on their faces, and too many products. The dermatitis around the mouth. What is this, and why would anybody think that it was acne?
Periorificial dermatitis is something that we see a lot in our dermatology clinics, and increasingly so, I think. And it can look a little bit like acne. So oftentimes we see it as a little bit of irritation, a few pimples, and kind of a dryness around. It's called orificial because it's usually around the orifices, so around the nose and around the mouth oftentimes. Classically, the way we have been kind of trained in dermatology is that this occurs after steroid use. So your patients with inflammatory skin conditions who may have had steroids on their hands and put their hands near their face can get it. And then weaning off just the steroids makes it a lot worse. However, we are seeing this type that is just related to overuse of skincare products, overuse of active ingredients. So you're seeing a lot of that.
Yeah, and the profession that I think is most vulnerable to this is beauty journalists, because they try so many products out, and it's more common in women, and that's probably because we already do use so many products to begin with compared to men. But absolutely, we see that. But then there's also a younger group of people that are trying to basically create their own skincare routines at home.
Yeah.
And there's real FOMO about missing out on ingredients. And we know not everybody needs every single ingredient that's on the market, but there's no doubt that it's a bit like, well, I want the niacinamide and I want the vitamin C and I want the exfoliating acid, but I also want whatever new ingredients come along as well. And before you know it, there's like 10 products that have been applied to the skin that aren't necessarily all supposed to even work with each other.
Yeah.
So I think...
And it's funny. I find the younger generation, it's such a generational thing.
Yeah.
The younger generation, so people in their 20s, know a lot about ingredients. And if you ask them if they have a complicated skincare routine, they'll say, oh, not at all. And then they'll show you their skincare routine and you'll go, that is extremely complicated. Whereas people in their kind of 40s and 50s don't really know as much about the products, because I think it's been something that's really only kind of become a vogue in the last probably 5-10 years. And their skincare routines are very uncomplicated, but they're just picking and choosing whatever they see as anti-aging, not knowing what's in it and lashing that on.
Yeah, and I think often, again, where it's just useful talking to someone where you can pick one ingredient that's got multiple benefits, because then you can just cut down the number of things that you have to put in your routine. So going back to vitamin A, which is a perfect example of this, yes, it has got the benefit of boosting collagen in the skin, but it's also good for pigment. And it's also good for acne. I mean, that's just 3 things ticked off in one go if you pick the right formulation, that maybe then you don't need the BHA, plus maybe the niacinamide, plus something else. So I think it's also being smart about the ingredient that you pick and how many boxes can you tick with it to reduce your steps.
Because it can be a really tricky thing to treat periorificial dermatitis. It seems quite trivial compared to really nasty, say, nodular cystic acne, but it can be really, really persistent. And one of the things that we have to tell people is that they have to stop using all of their skincare, which people really hate. And you're really stripping it down to some basics. Because I'd imagine if you've got it, you'd be wanting to put more stuff on it. Yeah. And I mean, that's oftentimes what happens. And sometimes they'll go to a GP or somebody who's not sure, and they'll get a steroid cream, and that really only makes things worse. And sometimes if you stop all the products, then there is actually a kind of a flare,
a rebound.
And we have to manage people through that. So it can be quite tricky, but we have to strip everything back, and then people obviously want to eventually reintroduce their active ingredients, and you can kind of do that quite slowly.
Yeah.
One of the things I've noticed actually about the Skin Diary, which wasn't intentional when we developed it, was that we have lots of patients now who have had periorificial dermatitis come through the program. And at the start, I was very gingerly putting people on things, because we do have lots of different ingredients, but they're rotated through different days, and they're on specific days for specific reasons. And the tretinoin's only in there twice a week. So, and we'd start off at low levels, but all of the people who've come through with the periorificial dermatitis, we've managed to keep them on and managed to increase them back up to really good levels of active ingredients. So that's been great, because I've had some really tricky cases. But I think basically with the active ingredients, there's a way to do it. If you're doing it yourself at home, just do it really, really simply. And just as Anjali said, just use, 1 or 2 ingredients.
Yeah. And when you said about the reintroduction as well, you change one variable at a time.
Yes.
So you bring in one product, and then if you're okay with that, then you bring your next product in.
I feel for the beauty journalists though, because you can imagine if you're getting all of these products in your door, you do want to just try them all.
Yeah.
But no, it's not a good idea.
No, it's not. I've been victim of that one myself with a giant red neck for many, many months after trying things. Was not fun. Difficulty in diagnosing things as well with just going back to rosacea and rosacea, which has the pustules and things. That's often misdiagnosed. Do you handle that? How do you, when you're looking at somebody, how do you tell the difference?
I mean, it's very clearly usually just a clinical diagnosis. You don't need any special blood tests that you need to do. You know, I think this is the thing where, as dermatologists, we're just trained to recognise the difference. I mean, yes, there are some textbook classical differences. You don't see comedones apparently in rosacea, but then that misses out the bit that some people have had adult acne and then they develop rosacea a bit later. But generally speaking, often what people will describe will be slightly different, and the look of the skin will be different as well. So you will often see a background redness with rosacea. It's usually on both sides of the face. It's symmetrical. Cheeks, nose, chin, where you normally see it. People will normally volunteer themselves. My skin is super sensitive. I can't put products on it. I get really red after I exercise or going from a hot room to a cold room. So all of those are kind of like alarm bells that will push you towards thinking of one thing versus another. Family history is massively relevant. If somebody tells you they've got symptoms around their eyes, they've had trouble with swelling of their upper or their lower eyelids, or a condition called blepharitis, that would push you more in the diagnosis of rosacea versus acne. But there is an awful lot of misdiagnosis that goes out. And the problem with that is if you slap on over-the-counter products that are made for acne-prone skin on somebody who's actually got rosacea, there is no doubt you'll make that rosacea worse and you'll make that redness worse over time. And there are, certain online platforms that are out there, for example, where people are given sort of very, very high concentrations of acne-type products, but patients are certainly making their way into clinics. And then you look at them and you're like, well, it's not acne, that's why it's rosacea, but that diagnosis wasn't nailed. And therefore, actually, the skin got worse, not better.
Yeah, and even with rosacea, there are subtypes of rosacea that we're very used to seeing. There are some people who have that papulopustular form of rosacea that is more acne form, but then we just see people with the kind of flushing and blushing types of rosacea, again, which goes along with being, unfortunately you can get flushing with the menopause, or you can get flushing and blushing with your rosacea. We have this erythematotelangiectatic rosacea, which is just kind of the broken pilaries, little vessels on the face, which really the only thing that can treat that are the lasers and light devices. So again, those kind of little subtleties are really, really important when it comes down to treating it and choosing the right treatment option. And oftentimes we have seen people who have gone down the wrong path for years before eventually coming and seeing someone about it.
Yeah. With antibiotics these days and acne in general, I mean, you still hear people being put on antibiotics for months and months and months and months and months. Is that still... I understand from what I've been reading that they're basically saying now that antibiotics really don't have such a great role in acne anymore, and there should be other treatments that should be looked at first rather than shoving people on antibiotics for 6 months. Yes, no?
So, I mean, I work purely independently. So my decision-making can be slightly different to maybe the way that certain NHS guidelines might sit and NHS protocols might sit. And there's no doubt that acne is in those, acne antibiotics are in those guidelines for acne to have been tried out first before you may go on to other treatments, or referrals can be made to secondary care or into hospitals to see a dermatologist. On a personal level, I do not like using antibiotics for acne. I don't think it's good to be on them for months and months on end for your gut health, for your general health, for risks of resistance. And there is data that shows that dermatologists are pretty bad at overprescribing antibiotics as well. So my personal preference is if there's an other way that we can find around it, that would be my preference. I would be happy giving antibiotics for maybe 3 to 4 months maximum. Any more than that, I personally feel uncomfortable with. And I would be looking at other solutions, particularly if there is a risk of quick recurrence and the acne just comes back as soon as you stop it. However, I think official answer here is they are on guidelines. And therefore, if you were to go to your GP first off for acne, which is the pathway that most people take, you probably will end up on them.
It's nice to have them as a kind of a quick solution if somebody comes into you and they are flaring. Again, as Anjali said, to use, for 3 or 4 months. while you're getting the rest of their skincare routine sorted. So maybe just to get somebody over that hilt. For things like rosacea, we do have very low doses of antibiotics, the tetracyclines that we can put people on that aren't actually used for their antibacterial quality, or just used as anti-inflammatories. So they're quite low dose and safe for long term. But yeah, I agree. It's not ideal having people on oral antibiotics for months and months and months on end. And you do see patients coming in who are really, they can't get off them because they've been on them for a year or two. And so we don't like having people on long-term antibiotics, because obviously that is not great for bacterial resistance developing, and also, again, for your gut health and gut microbiome. So I always get people to go onto a probiotic when they're on an antibiotic, and try and get them off it as soon as we get a good skincare routine set up for them.
Yeah. The other thing that's quite controversial is the Accutane. And, before there were risks that was associated with suicide, and generally people didn't really like it. Where are we now with that?
So I think isotretinoin, or Accutane or Roaccutane, depending on where you live and how it's colloquially referred to, it's a vitamin A drug, and it's a very, very effective drug for acne. Now, like all medications, not every medication is suitable for every individual. And generally, we reserve it for people that have either got acne, which is scarring, or acne, which has failed to respond to other treatments. There are a long list of side effects that go with that. However, most of those side effects can be managed. That's why you're monitored so closely whilst you're on it, and you have blood tests whilst you have it. From the mental health point of view, I mean, I know what's out there, but from a practical point of view, I think one of the things that gets overlooked in all of this is if you have severe acne, by definition, that acne is severe enough that it probably is affecting your mood and your self-confidence and your self-esteem. And the question then becomes, in those odd cases of low mood that has been reported, has it been because there has been a pre-existing issue that has been identified, or because the drug is genuinely causing a new problem?
Yeah, that's the interesting thing, isn't it? Because nobody really asked that in the beginning, what the mental health of somebody was before they started it, and then they sort of noticed this. But then it was how were they before? And I wonder whether or not we'll actually find the same things with the semaglutide.
Time will tell.
Yeah.
Time will tell. I think the advice I tend to give is, from a practical point of view, these are the risks. On a population level, we have not found any clear evidence that this drug causes mental health issues. However, on an individual level, there may be some people who are more susceptible to the mental health effects. And that's just completely then disregarding if there was a baseline issue of mental health disorders which were there to begin with. I mean, when we consult a patient, we do ask them, have you got any history of any mental health issues? Is there a family history of any mental health issues? So people are given the option. And if there is somebody, certainly in my practice, that I think actually they're not suitable for the drug, I'd feel uncomfortable give it to them, I would actually offer them the acne laser Avaclear instead, because there is that additional option. So I think it's about options and making sure that we discuss with our patients, they recognise what the pros, the cons, the risks and benefits are, so they can decide for themselves what they want to do.
Yeah.
All in all, we do see fantastic results, and we see very, very happy patients. And as dermatologists, we have been prescribing Accutane or isotretinoin for many, many years to millions of people around the world, very, very successfully. And it has been life-transforming for people, and we've seen it with our own eyes, patients who come in and, they are so thankful that you've kind of helped them to make that decision to start on it, because their lives have completely changed, like young Anjali before she started college. So, I mean, it's something that we will continue to prescribe and continue to want to prescribe and give to our patients.
Yeah. You mentioned there, now, because we don't think of lasers, we often think of lasers for sun damage and for ageing skin, but not necessarily as a treatment for acne. So tell me about these lasers. What do they do and how do they work?
So it's interesting. So we've always had energy-based devices or lasers that could treat acne to some degree, but a lot of the lasers that were out there previously either worked by knocking off the microbiome of the skin for a short period of time, or knocking off oil gland activity for a very short period of time, but they did not give any permanent or long-lasting results, because your skin microbiome just comes back. So there is a new laser called the Avaclear laser, and that laser specifically only targets the oil glands in the skin. So what it will do is you fire the laser at the skin, that laser will then shrink down your oil gland. You shrink the oil gland down, your pores don't get blocked. And if your pores don't get blocked, the bugs that live on your skin have got nothing to act on to create those deeper spots. So what's different, I guess, about this laser is it's FDA approved for long-standing results. So people are still acne-free 2 years on, which is pretty incredible because if, for example, you say do a course of isotretinoin, the risk of relapse is actually highest in the first 2 years of you stopping the drug. The second thing is the laser is actually also licensed for the treatment of mild, moderate, and severe acne. So we've never had a laser previously that could treat nodular or cystic acne. So that's actually quite a big deal. The other thing is because the laser doesn't break the skin, it's non-ablative, what that means is there's pretty much no recovery time with it either. You can walk straight out having had your treatment done, and it's 3 treatments, 3 weeks apart, and your treatment is complete, and carry on with your regular activities. So again, it's not a replacement for isotretinoin, but it is an additional option for people that can't take the drug or don't want to take the drug.
Yeah, it's fantastic to have that extra tool in the armamentarium because it really is a game changer. When you think of it, of the patients who maybe just don't want to go on isotretinoin for the reasons that we've discussed, and we don't want to leave them on long-term antibiotics forever, it's great to be able to, I've referred a few patients now to Anjali for that, for this option. Yeah. And you're seeing good results in your clinic? We
are actually. So the laser actually had its European launch in February. So it's been available in North America for about coming up to 3 years now. So we've got 3 years of data from the US, and then we've got 6 months plus of data from like UK and Europe. And we are now one of the biggest international global users. So we've got a lot of our own in-house data as well. Like everything, though, it's not perfect. Things do not work immediately for everyone. So what we tend to say to people in terms of how quickly will you see results, about 30% of people will clear at about 3 months, 60% about 6 months, 90% at about 9 months.
And how many sessions would you have to have?
3 sessions, 3 weeks apart. So the results seem to get better as time goes on. The second thing with it is in Canada, it is actually FDA approved for acne scarring as well. So a lot of the patients that are actually having it for active acne are also noticing that their scarring is actually improving a little bit as well. Although we don't have that license in the UK to be able to say that. So that's just what we're noticing in-house.
What about
rather than elsewhere.
Rosacea?
So we have used it on a couple of acne rosacea overlaps, and we're getting good results with it. But there's a little bit more data that I'm keen to dig around on because we've also noticed that those particular patients that have got that rosacea overlap, their redness has reduced as well. And logically thinking that through, this laser is not targeting hemoglobin. So I'm curious as to why we're seeing that. Yeah. And these are patients that we've not done any other laser on to actually reduce their redness. And we have noticed there is a clear reduction in redness, not just the bumps or the papules or the pustules.
I suppose if you're reducing that inflammation, going along with that, you're reducing the redness. But that's great. That's also another good thing to have. We do use the isotretinoin, again, quite a bit for people with very persistent, difficult to treat rosacea. And you can use that more long-term at low dose, even just once or twice a week in patients with rosacea long-term. And that's quite good because it's nice because they get that little bit of a bump for their skin as well as for reducing the rosacea symptoms.
Yeah. Interesting. I like that microdosing for rosacea patients. It works really, really well.
Yeah.
Yeah. You mentioned before with acne, though, not using tretinoin around the eyes, but for general aging skin, can you use it around the eyes or is the skin too sensitive?
Oh, you can. Again, it's all about, the dose is the poison. Yeah. So you just need to use it at lower doses or do that sandwiching technique, put your eye cream or just your moisturizer on first and then put a little dab of your tretinoin. Usually what I tell people is, put it on their face first and whatever little bit of residue that they have still left on their finger, just kind of dab that a little bit around the eyes. But I find it quite good for that skin around the eyes because oftentimes when the skin is thinning as you get older, you notice it first around the eyes because you don't have that layer of fat like you would on your cheeks. You know, around the eye, you just have the dermis coming into basically muscle. And as the dermis thins, because the collagen and elastin is lost, you can see just the muscle and the blood vessels behind. And that's often what the dark circles are. So by applying a little bit of a retinoid, which will increase the collagen, people really notice the difference around their eyes. Those little white bumps that people often come about. They think they have milia around their eyes. And, I often get asked to to take them out, but they're actually just the little pilosebaceous glands that you can see because the skin, the dermis around that has thinned, so you can see the glands much clearer. And it's great because when you use good skincare like your vitamin A's and your vitamin C's that increase the collagen, they basically disappear.
Wow, interesting. With the acne and the laser and the scars, does it work? Because we've got different types of scarring. You've got those rolling scars, the pitted scars, box scars. Does it work on all types, or have you found it works better on specific types?
Do you mean the Avaclear laser for active acne? Or do you mean generally lasers that we use for scarring?
Both really. Yeah. I mean, if not that one, is there another one then that would actually?
I wouldn't use Avaclear as my go-to for acne scarring. From an acne scarring perspective, and I think we touched on this earlier, but you cannot make the skin look the way that it was before that scar process took place. So what's considered to be a good outcome is about a 50% improvement in scars. Now, there are some factors that you can control that will maybe make that higher than 50%. And then there are some factors that are out of your control, even before you choose the device or the laser. So when I do the laser consultation, I will always ask firstly about diet, because I do find that if somebody is vegan or they are plant-based, it's not that you can't be healthy on those diets, but I generally find that those people often may be slightly lacking in things like B12, omega-3s, zinc, selenium, Vit C, the things that you actually need to build new healthy skin. And that's why I really want to make sure the diet is optimized. So if somebody wants a laser treatment and they're plant-based and they're not supplementing, I will tell them to supplement before I will treat them. Yeah. The second thing is the time of year that you choose to do the treatment. You know, if you're going to do a fairly heavy-handed treatment, if someone's got significant scarring, you probably don't want to be doing that in the height of summer. So that's a second thing that you may want to consider. And then there are things that you can't control, which is the genetics of one's own wound healing. You know, you don't pick your parents. So some people will just heal better than others. The second thing I would say is when you are treating scarring, you have to prepare the patient that it will be more than one treatment. It often is multiple sessions, and it's often combining different modalities of treatment, because usually what you find is when someone's got scarring, they don't just have one scar type. They might have a couple of rolling scars, which are kind of soft and up and down. And they might have a couple of box scars, which are much deeper and look like craters. So really what you have to do is you have to combine methods. And how you choose to combine those methods will vary from practitioner to practitioner. It doesn't mean that one is right, one is wrong. It's just different people use devices in different ways to get the outcomes that they want. So the two gold standard acne scar lasers are your erbium YAG and your carbon dioxide laser. So they're the ones that have got the most data on them. So usually they would be our go-to lasers. But if I was going to do a treatment of a combination of scar types, I would probably do something called subcision, where if the scarring is pulled down or tethered, I want to break those tethered bonds up. I would then probably deposit polynucleotides, which are biostimulatory to encourage collagen as I'm pulling that cannula out where I have done the subcision. If there are deep scars, I would probably put in something called TCA, trichloroacetic acid, at about 90% and paint them in. And then I would laser on top. And then I would choose an erbium YAG if somebody has got darker skin type. And I'd probably choose a carbon dioxide if they've got fair skin types. But that's just one way of doing things. So there are lots of different ways one can incorporate things. And that's why a consultation is so important, to assess the extent, the severity. Is it face? Is it back? Is it somewhere else? So you can pick and choose. And the patient can also be comfortable with the options they've been given.
Yep.
Yeah. Again, with acne scarring, just as Anjali said, there are so many different types and we treat them all quite differently. Yeah. It's interesting what you said about the vegans and the plant-based diet, because we see that very much in skin surgery as well, that the wounds just do not heal as well. And it's only something that I've recently started asking patients. Yeah. And if they are vegan or have a plant-based diet, I'll ask them to supplement with amino acids before surgery a few weeks beforehand, because their wounds will heal better. But
so you're wanting them to make sure they've got a lot of protein as well then, yes?
Yeah. One of the things I find that's a real double hit with acne scarring is it often actually gets worse as you get older.
Yeah, it does.
So sometimes we find people are only in their 40s and 50s when they come for treatment. Their acne has been and gone as a teenager, but actually they're only coming for their lasers or acne scarring treatment in their 40s and 50s. And that again is because with the loss of collagen, and also because the loss of the structure underneath your skin. So your structure under the skin is like the table and your skin is like the cloth on top of that. So the bone and the fat and everything resorb and everything else kind of just sags slightly, and this acne scarring unfortunately gets worse. So but things like the hyaluronic acid fillers and polynucleotides and lasers and all these different things that we use can get things better, but only a certain amount better. And definitely skincare has a role to play. You know, topical retinoids, sometimes that's all patients want, is just a minor improvement, and they're happy with that, just to know that they're doing something for their skin, and giving them a good skincare routine and then telling them about all these other invasive treatments. Sometimes they will just pick the skincare routine.
Yeah, I think it's about options and choices. Yeah. And I think the good news is if you have got acne scarring and you're older, I mean, the treatments that we use for scarring are basically the treatments that you use for rejuvenation. Yeah. Because you're trying to boost collagen at the end of the day. Yeah. So you can get a double hit with it if you wanted to.
Yeah, that's the good news.
At least there's some good news. Yeah. Top tips, ladies. What are your top tips then for women in perimenopause who are heading down the finding that they're getting breakouts again and want to avoid them? Top tips.
I'd say make sure that you get expert help. I think that's really quite important. I think it's very easy to end up spending lots and lots of money on, unfortunately, very poor advice. And I think, do your research on making sure the person you go and see is qualified to be able to give you that advice.
Mm-hmm. Agreed. I mean, it doesn't have to be a dermatologist. There are some very good GPs with specialist interests and aesthetic doctors as well who are quite qualified to give this advice. But I think, if you are struggling, definitely seek expert help rather than trying to go it alone. Yeah.
Ladies, thank you so much for that. That was an absolutely brilliant conversation.
Yes,
if people need to find you, darling, where do they find you?
So you can find me at South London, which is on 14 Harley Street.
Wonderful. And the Skin Diary, if people wish more information about that, where do they find that?
Well, the website is simply theskindiary.com. Thanks for coming, Anjali. Hopefully we'll get you back again soon to talk more acne and more menopause and more skincare.
Thank you.
Thanks.